Clinical vignettes in musculoskeletal medicine are constructed from a high density of overlapping physical findings. A patient presenting with localized bone pain could have anything from a benign cyst to an acute vascular emergency. Navigating these scenarios requires a system that defines the immediate next best step. This is the MSK triage grid. It is a strict diagnostic algorithm that categorizes ambiguous symptoms into rigid deductive pathways based on objective clinical data. The first branch isolates iatrogenic triggers. Before assessing trauma or oncology, we examine the patient's pharmacological history to determine if chronic steroid or bisphosphonate exposure is the underlying cause of bone death. The second branch assesses oncological alerts. Here we differentiate primary bone tumors by correlating the patient's exact age demographic with the specific radiographic morphology of the lesion. The third pathway identifies infectious and ischemic complications. The differentiator here is the chronology. We separate immediate surgical emergencies, like acute compartment syndrome, from prosthetic joint failures that evolve over several months. The final branch captures neuropathic and autonomic dysfunctions. This pathway identifies regional pain syndromes following trauma and diabetic foot deformities, where the sensory system itself is the driver of joint destruction. By filtering symptoms through these parameters of timeline, age, and location, the differential diagnosis is no longer a matter of subjective interpretation, but one of algorithmic logic. High-dose glucocorticoid therapy can rapidly disrupt the cellular balance of bone remodeling. The suppression of osteoblast activity and the promotion of osteoclast-mediated resorption induces a state of systemic osteoporosis that necessitates preventative intervention. The clinical protocol for these patients includes minimizing steroid dose and duration, performing baseline DEXA scans, and initiating bisphosphonates to maintain bone mineral density. However, the use of bisphosphonates to treat iatrogenic bone loss introduces a specific secondary vulnerability. High-dose or parenteral bisphosphonate therapy can precipitate a localized crisis in the jaw. This intersection defines the risk for bisphosphonate-related osteonecrosis of the jaw. The condition is most likely to occur when high-dose bisphosphonate use is combined with chronic glucocorticoid therapy and an invasive dental procedure. Patients present with indolent jaw pain, loosening of the teeth, and areas of exposed necrotic bone that may eventually lead to pathologic fractures. When localized bone pain occurs without a clear medication history, the diagnostic focus shifts to the oncologic branch of the algorithm. One classic presentation is the osteoid osteoma. This benign tumor is defined by a prostaglandin-producing nidus that causes significant night pain, which is uniquely and completely relieved by NSAIDs. Osteosarcoma follows a strict bimodal distribution. In adolescence, it typically develops at the metaphysis of long bones. In adults over 40, it develops as a secondary malignancy at sites of prior bone damage, such as Paget's disease or previous irradiation. Ewing sarcoma is a distinct adolescent pathology that prefers the diaphysis of long bones or the pelvis. Unlike other bone tumors, it often presents with systemic findings such as fever and leukocytosis, mimicking an acute infection. While some bone tumors remain localized, Ewing sarcoma carries a high probability of early systemic metastases. These malignancies are differentiated by specific periosteal reactions on imaging. Osteosarcoma typically presents with a Codman triangle, while Ewing sarcoma produces a lamellated, onion skin appearance or a destructive, moth-eaten pattern. Giant cell tumors follow a different anatomical rule, appearing in young adults and remaining strictly isolated to the epiphysis. Tumor differentials are not solved by the intensity of the pain, but by aligning patient demographics with the specific anatomical location of the lesion on a radiograph. On the infectious and ischemic branch, the time elapsed since a surgery or injury dictates the likely pathology. Prosthetic joint infections are categorized by their onset. High-virulence organisms cause acute symptoms within the first 3 months. Low-virulence organisms, such as coagulase-negative staphylococci, cause delayed presentations between 3 and 12 months. These delayed infections present with chronic pain and implant loosening. The required management is the removal of the joint and the administration of antibiotics prior to any attempt at reimplantation. When the timeline of symptoms is measured in hours following trauma or vascular reperfusion, the focus shifts to acute compartment syndrome. The early presentation is defined by tense swelling and severe pain with passive stretch. It is important to note that the loss of pulses and motor paralysis are late findings. Waiting for these signs before intervening results in irreversible tissue death. The definitive diagnostic metric is the delta pressure. When the diastolic blood pressure minus the compartment pressure is 30 millimeters of mercury or lower, tissue perfusion is inadequate and an emergency fasciotomy is required. This acute crisis is distinct from chronic exertional compartment syndrome, which is characterized by pain that is strictly exercise-induced and reliably relieved by short periods of rest. In post-trauma triage, patient reports of pain are nonspecific. Objective pressure thresholds and strict chronologies are the only metrics that prevent permanent functional loss. The final branch of the algorithm addresses presentations where the nervous system itself drives localized joint destruction or regional pain. Charcot arthropathy is driven by profound sensory loss, typically in diabetic patients. This neuropathy allows repetitive, unnoticed microtrauma to occur during weight-bearing, which progressively destroys the joint structure. The clinical progression moves from an acute, warm, and swollen foot to chronic midfoot collapse and the formation of extra-articular bone fragments. Complex regional pain syndrome, or CRPS, presents as a severe regional burning pain that persists following a minor trauma or surgery. A diagnosis of CRPS requires specific physical evidence of autonomic dysfunction, including abnormal sweating, vasomotor temperature shifts, and trophic skin changes in the affected limb. Management focuses on medical and physical therapy, including specialized range of motion exercises and NSAIDs, rather than surgical intervention. Failing to recognize autonomic involvement leads to unnecessary and irreversible surgical interventions for what is a medical pathology. We can conclude with a rapid-fire matrix to isolate several highly testable physical findings. Post-amputation pain is differentiated by etiology: focal stump pain, ischemic pain, the localized tenderness of a neuroma, or the sensory illusion of a phantom limb. Punched-out lytic skull lesions appearing in a patient with symptoms of diabetes insipidus are the hallmark of Langerhans cell histiocytosis. Myositis ossificans presents as a delayed intramuscular calcification following blunt trauma. Radiographically, it appears as a solid peripheral mass with a radiolucent center. A rubbery nodule on the wrist is diagnosed as a simple ganglion cyst when it successfully transilluminates under a direct light source. When evaluating a pediatric limp, active investigation with synovial fluid analysis is required to rule out septic arthritis. In contrast, physiologic bow legs in a child under age 2 require no intervention and will resolve. This is the completed MSK triage grid. Every clinical presentation has been filtered through an objective parameter and mapped to its correct diagnostic endnode. Mastering these vignettes is not a matter of memorizing descriptions of pain. It requires plotting chronological timelines and anatomical constraints onto a decisive and uncompromising algorithm.